Colonoscopes are longer and mostly less stiff than gastroscopes. Up to 30 centimeters from the tip, all colonoscopes have floppy pediatric characteristics, and the bending section is longer than a gastroscope's to avoid impacting at angulations. Otherwise, the air-water and suction valves, the angulation controls and switches are all the same as on a gastroscope. There's a carbon dioxide connection on the umbilical or the water bottle, and older scopes have a connection for a lens flushing syringe. Standard colonoscopes are around 13 to 15 millimeters in diameter, with instrumentation channels between 3.2 and 4.2 millimeters. Larger channels help suctioning residue or blood clots and are easier for passing dilating balloons or decompression tubes. Colonoscopes and gastroscopes differ in that their instrumentation channels are on opposite sides relative to their viewing lenses. This endoscopic view shows the colonoscope forceps emerging on the right, in contrast to the gastroscope where they emerge from the left. Conversely, colonoscope insufflation bubbles on the left, but gastroscopes on the right. Compared with standard long colonoscopes, the pediatric colonoscope is shorter at 130 centimeters, around 1 centimeter diameter, with floppy shaft characteristics and a shorter bending section. This makes it easier for passing diverticulosis or strictures, but more difficult to reach the cecum in long, mobile colons. The acute angulation of a pediatric gastroscope can sometimes be better still in severe diverticular disease. The magnifying or zoom colonoscope has either a twist control, a thumb control, or a foot switch to zoom the view. This gives better resolution of surface detail, especially if dye spray is used to enhance the surface view. The Interflex variable colonoscope gives the endoscopist control over scope stiffness. It has a variable stiffness insertion tube. Twisting the stiffness control varies the insertion tube flexibility from stiff to floppy. Inside the scope there's a stiffener coil and pull wire. Turning the stiffness control tightens the pull wire, compressing the coil and stiffening the insertion tube. The last 30 centimeters to the tip stays unchanged and floppy at all times. This Scope Guide 3D Imager view shows how, even after straightening, a colonoscope tends to reloop in the sigmoid and make passage around the splenic flexure difficult. This animation shows why. The sigmoid stretches upwards. Pulling back and then stiffening an Interflex colonoscope holds the sigmoid straight, letting the scope tip slide in, avoiding the need for abdominal pressure or position change. It's then usually best to reduce stiffness again. It's more comfortable, the scope slides in better, and it avoids straining the stiffening mechanism. The splenic flexure is where Interflex stiffening is particularly useful. But even proximally, reaching to the hepatic flexure or the cecum, the stiffer mode can be useful. My own experience is that being able to optimize things for the individual bend or the individual patient is the bonus offered by Interflex colonoscopes. Being able to choose to change insertion tube stiffness during the procedure is a wonderful feeling. It also avoids having to guess beforehand which colonoscope to choose or having to change scopes and to start all over again.